talk about antibiotics in general because all of us will touch antibiotics in one way, form, or another. And this is really a partnership between all of us here and people out there. Everybody out there comes in here, and then we deal with antibiotics. You, me, everybody and patients. So I really want to start off by asking who thinks antibiotics is a good word? I really do. I think antibiotics really is a good word because antibiotics have really changed the face of medicine. About 50% of mortality, morbidity was related to infections back in early 1900s. And look at where it's come down here. Over time, by early 2000s, we brought it down to less than 3%. So antibiotics has really shifted the face of medicine over time. This is modern medicine I'm talking about. We're able to do organ transplants, we're able to take care of heart disease, we're able to do procedures, cancer treatments. All of these are affected by the advent of antibiotics, right? Alexander Fleming found penicillin in 1946. He said that the public will demand and the abuses will begin. So while we have changed the face of medicine with antibiotics, we really have to be able to contain the appropriate use of antibiotics where all of us are involved, because we don't want to be seeing these multi-drug resistant organisms 10, 15, 20 years from now, because we really don't have those medications available to us down in pipeline by the pharma companies. So while, interestingly, infections have gone down in so many years, in 60, 70 years, heart disease and cancer has gone up. While we're able to handle the procedures, while we're able to handle these complicated transplants with antibiotics, we're seeing a rise in the diseases related to heart disease and cancers. So I wanted to kind of just bring up the importance of how antibiotics is really good and why we need to protect them. A really famous lecturer, physician, poet, really, he was an eminent physician in the 30s. I just wanted to read this and have it really sit in our heads. For most of the infectious diseases on the wards of Boston City Hospital in 1937, there was nothing that could be done beyond bed rest and good nursing care. That was it. Bed rest and good nursing care is what we were able to do until sulfonamides came about. When sulfonamides came out, you can see these are a whole slew of classes of antibiotics that just burst into the pharma companies that were able to bring to us where we were able to fight off infections. So from the 30s, you can see beta-lactams came about, aminoglycosides, glycopeptides, the azithromycins, the doxycyclines. But really, you can see after 70s and 80s, where we started to see a whole burst of classes of antibiotics that the pharma companies were providing, there was a sudden halt in the 70s and 80s. They stopped manufacturing these classes of medications for gram-negative organisms because it was just too difficult to catch up to the profits that they thought that they would make because the bugs would form resistance. So they'd come up with this nice fancy antibiotic. The bug will come right along and form mechanisms of resistance, and that company just lost all of its sales for that drug because the bug was too smart, right? So really the pharma companies saw no use, unfortunately, because then you've got patients with multi-drug resistant organisms where you don't have those antibiotics to handle them. So we really don't have too many new classes of antibiotics. We're mixing and matching with what we already have, trying to see if it can do better, but we don't have new classes of antibiotics to treat these infections. This is a little small, but really what I want to show is a timeline of the drug that was seen and manufactured and the bug that is resistant to that drug. So you can see over time from 1940s to 2010s, you'll see a new drug that a company might manufacture, but then you have streptococcus that's resistant to erythromycin. You have enterococcus that's resistant to gentamicin. You have Enterobacteriaceae that's resistant to cephalosporins. So it's really we're catching up to the bug that's already formed resistance. So these are the reasons why we really need to see what we can do as a community to save these antimicrobial classes. And these are the the bugs are really smart. We come up with these antibiotics, and they know what type of mechanism to use to shun that antibiotic out. Whether it's a beta-lactamase, whether it's a pump within that bug to just push that antibiotic out, whether it's just a little DNA mutation that they've got to no longer accept that antibiotic. So whatever antibiotic class we've come up with, that bug has become smart to get rid of it. So we just need to be aware of it and trying to get more specific ways of trying to get rid of that bug in many ways that they're trying to come up with. So what we're seeing really is the resistant bacteria going up, and I just put a slide here to show what type of resistant bacteria we're dealing with. We're dealing with MRSAs, we're dealing with vancomycin resistant enterococci, the VREs. We're dealing with Pseudomonas aeruginosa that's resistant carbapenems. Carbapenems were really, they came about to target the Pseudomonas that would form resistance against the cephalosporins. So the carbapenems were introduced, but now we have Pseudomonas species that are resistant to carbapenems. We have Acinetobacters. Luckily in this area, we're not seeing too many Acinetobacters and Pseudomonas resistant to those classes, but we are seeing some MRSA and a lot of VREs. The more vancomycin we use, the more VREs we will be seeing. So use of one antibiotic class will create resistance for another antibiotic class. So it's pretty scary. And we're starting to see a yeast species that are resistant to the common antifungals that we have out there. So as we're seeing the antibiotics in the pipeline that are manufactured less for various classes, we're seeing a rise in the resistant bacteria. And this is all out in the internet. You guys can go into Google and just find that families are reporting their family members dying of multi-drug resistant organisms. These are MRSA, ESBLs, carbapenem resistant organisms, C. diff, which we have been seeing more and more in the hospital. So this is out there. What we need to know is that the morbidities associated with these illnesses and the multi-drug resistance associated with those, not just the morbidities, because you've got over 2 million that are reported per year, but the number of deaths associated with the multi-drug resistant organisms. That's pretty staggering when you start to look at the numbers of multi-drug resistant organisms that are rising and the associated deaths that are associated with that. When you start seeing multi-drug resistant organisms, we start to use more antibiotics. We want to try to get rid of them more, and when we start seeing that, we start to see that we're seeing more C. diff, Clostridium difficile prevalence in the community. Not just the illnesses, but the associated deaths associated with Clostridium difficile. So these are tough organisms to get rid of, and then this is a really tough organism to get rid of as well. So if we can't get rid of, the best way to treat an infection is not get it in the first place, right? So if we don't get the multi-drug resistant organism, we don't have to be dealing with its associated morbidities, we don't have to be dealing with C. diff. But unfortunately, that's not reality, so we have to find ways to treat them. So I wanted to just bring this up that was posted by the CDC. How do we get multi-drug resistant organisms? So antibiotics are out there, right? And we need to really see who needs antibiotics and who don't. So when you go out there, and you hear patients ask for antibiotics, I really want all of us to say, do we really need the antibiotic? Is this an infection or is it colonization? I'll talk about that in just a bit. But here you have antibiotics. Patient is, here's a person who ingests antibiotics because he was given antibiotics. And antibiotics go into whole cycle in the agriculture. That's not even being regulated. At least here we have all of us to ask each other why we need antibiotics. Nobody is regulating what kind of antibiotics go out into the farming and the agriculture realm. So you see these animals that get antibiotics, the byproducts that go into soil, whether we're vegetarians or not, we're seeing these antibiotics. Patients go into units, ICU units, or they get in shock because of multi-drug resistant organisms, not because they only see antibiotics and they fall into this cycle where they come into the hospitals, but they eat maybe ground beef that has been treated with antibiotics, they ingest this, or the vegetarians may ingest foods where the fertilizers are used and treated because of the runoff from the animals that have seen antibiotics. So it really is we're all exposed to this, whether we're vegetarians or not. This cycle we all fall part of. Here is where we have some control. Here is where we can decide whether patients need antibiotics or not. They eventually go into a hospital system if they get admitted. All of us are exposed to these patients who have multi-drug resistant organisms. They go back out into the community, and it doesn't take much to spread these organisms amongst each other. So really, over time, it's only a matter of time till we all get some form or get exposed to these organisms. It's out there now. So now that patients put family members' information out on social media, the news, the TV media, all of them, they're posting where patients and families are concerned, everybody else is concerned, and they're posting where multi-drug resistance, antibiotic resistance is a big concern. So we talked about the resistance and why resistance is such a big deal. It's not just about the multi-drug resistance. It's about when a patient comes in when they really didn't need that antibiotic, and we deal with this all the time. They have this big rash that we have to deal with, and that takes several days for that to get better. And it's not just a rash. They can get Stevens-Johnson syndrome. They can get erythema multiforme. So it's a side effect of that medication that could have potentially been avoided if they didn't have to have that antibiotic in the first place. Of course, when we needed the antibiotic, like we showed that first graph, we saw a big change in mortality. But when we don't need the antibiotic, we can avoid these hypersensitivity allergy effects, the side effects of drugs. Bactrim, for example, it's readily given in the outpatient setting. Patient may or may not have had a UTI, but it was simple to give because the patient asked the doctor that I wanted, or the NP that I wanted the medication. They would have gotten the medication. And we see them with acute kidney injury or hyperkalemia related to that exposure to the antibiotic, and we don't know whether they even needed it or not. I see many times patients come in with acute kidney injury because they were not appropriately dosed for their kidney function. So if they had acyclovir, for example, for herpes encephalitis, maybe it wasn't dosed appropriately for their kidney function, and then we end up seeing them because of encephalopathy related to acute kidney injury or the psychosis related to that medication. So many issues that we could potentially avoid, if that medication was really looked at and we took a step back to see if that patient really needed the antibiotic. Of course, everybody knows about Clostridium difficile. We can talk about that in just a little bit. And the antibiotic itself can cause diarrhea and colitis, as Klebsiella oxytoca is one of those organisms where, just like Clostridium difficile can cause colitis, antibiotics, when you see enough antibiotics, we select out other organisms in the gut, such as Klebsiella oxytoca, and that can cause colitis. C. diff has just gotten the limelight and the spotlight on it, but there are other organisms that can cause colitis as well. And of course, all of this, when we really didn't need antibiotics in the first place, it affects you, it affects me, it affects that patient and their family, and they end up posting the information. Why? Because it affects their pocketbook at the end of the day. And the insurance companies, where they play in all of this, I don't know, but it really affects the healthcare in the big picture, all their costs, our costs. So in this setting, we're able to talk about antibiotic stewardship. So this is all of us, we are doing this because you and I and everybody else in this hospital, we ask whether a patient needs the antibiotic. Is this an infection? Is this a bug that we need to treat? If we need to treat, we're seeing results. So in the hospital setting, we're able to show that there's a cure for that infection when they needed it, or not. But having an effective antimicrobial stewardship program has been shown to have success when it has to do with infection. What we don't have and we lack is an antimicrobial stewardship program in the outpatient setting. And eventually, I hope in the next 10, 15, 20 years, I'll be able to talk to you and talk about an effective antimicrobial stewardship program in the outpatient setting, because that's really where we need this. what's ordered out there is what patients come into the ED, and many times what comes into the ED is not necessarily infection. About 50% of the time they get antibiotics and they don't need antibiotics, and we end up seeing those patients hospitalized because of possible side effects as a result. So we're seeing effects, great effects of antimicrobial stewardship programs here. When you may see when antibiotics are started when the patient first comes in, we don't know whether they have infection or not. They come in with sepsis, so we end up starting these patients on antibiotics. But we start them on broad spectrum antibiotics. We may start them on 1 or 2 classes of antibiotics because we initially suspect infection. That's okay. I mean, we all have to think about infection because the mortality from infection used to be really high, and because of antibiotics, we're able to bring that down. So, but we just need to give ourselves about 48 to 72 hours to make that final call of infection or not. So initially we can have a working diagnosis of infection, whatever infection it may be. Sometimes there may not be a source, but at 48 and 72 hours, we just need to step back and say, are we really dealing with an infection? Do we really need these antibiotics? Or do we have enough information, culture data, we have imaging data that does not support infection, and can we start to pull off antibiotics? And that's what directed therapy is, where we now start to define infection better. We're able to narrow those antibiotics. Maybe we don't need vancomycin after 24, 48 hours because we have blood cultures that don't show MRSA. That's really where you need vancomycin. If you're not seeing MRSA, we can take vancomycin off. And like I started off, we really don't have MRSA. Our prevalence of MRSA in the community is starting to decrease. So once we have enough information that we're not dealing with MRSA, that's the first drug that can come off. So we can start to narrow our antibiotic spectrum based on the data we have available, and ultimately we can decrease the adverse effects and the cost for everybody, the entire healthcare system, by doing that. Again, going back to empiric therapy, when do we need empiric therapy? When they're literally dying, when they have a limb-threatening infection, when they have necrotizing fasciitis, when you know that whether you do antibiotics or not, the likelihood of them dying is very high. You want to give them the best shot they have, and that's antibiotics. Again, that's empiric therapy until that 48 to 72 hours. Sometimes we don't have data to suggest whether it's a pneumonia or not, or cellulitis. You can't culture skin and say that we're dealing with this culprit organism. For many of the organisms that cause cellulitis, which is mostly strep species, you can't culture strep from skin. It's one of the strep species. So based on the data that's out there in the literature, that group A, group B, group C strep is associated with cellulitis. I don't need vancomycin. So, and typically MRSA is associated with suppurative cellulitis. So you see these abscesses and furuncles and carbuncles. That's when you use vancomycin. Otherwise, you don't need them. So based on historical information, epidemiologic data, we can start to pull off antibiotics when we don't need them. And we really need to use the negative cultures to help us. So if the culture is negative, that really helps us decide, especially Staph aureus grows really fast. So within 24 hours, if it were to grow, it would grow. And if it hasn't grown, then we can stop vancomycin. So if anything out of all of this we can stop, if I can get through, is that we can stop antibiotics when there's no Staph aureus or MRSA. And a lot of times you'll probably hear this, they got better because I had the patient on antibiotics, and after 3 or 4 days I see that, they're getting better, so let's just keep the patient on antibiotics. No, they're actually doing more harm than good by keeping them on that antibiotic. Yes, they're getting better because of fluids and all other supportive management that you're doing. Of course, if it's infection, I'm just saying when they don't have infection. If they have infection, you need that antibiotic, narrow that antibiotic, and target that antibiotic to that disease process. Again, directed therapy, I push clinicians to define where the infection is. It makes a big difference to treat when you're treating cystitis, urethritis, urethritis, or pyelonephritis. There's a big difference in how you manage them, because sometimes I'll hear, the patient has E. coli. pyelonephritis and bacteremia on and it was susceptible to Rocephin, we keep them on Rocephin, and by day 3 and 4, they still have a fever. Oh, should we broaden them? No, we don't need to broaden them, because if it's pyelonephritis, you expect to see fevers for several days until they get better. So if it was cystitis, you would only treat for 3 days, you put them on the appropriate antibiotic, but after about day 4, 5, or 6, they don't have back pain, yet they have fevers, and you've treated what you thought you treated appropriately for cystitis, then we have to look for an alternate source and an alternate etiology to explain that fever, not just broaden antibiotics because they have a fever. So I just want to bring that point across, because please question anybody who just continue antibiotics without defining anatomically, microbiologically, and really what's going on with the patient. If they don't need the antibiotics, they should be able, we're all accountable to each other, so we should be able to explain why we're using something and why we're not using something. And I'm pushing this in the ED folks out there, and as much as possible, if you can push everybody to get blood cultures, any cultures really, before antibiotics are started, in that 1 hour mark for shock patients and the 3 hour mark for everybody else. Any type of diagnostic workup we can do before we start antibiotics will help address source control that much faster. Because if we just start antibiotics and we get the patient up on the floor because it's just faster to do it that way, then we come back and say, well, I don't know if we're dealing with infection. Then we have to stop all those antibiotics, reevaluate the need for infection, get the biopsies and get the various diagnostics to then decide whether they need antibiotics or not. The patients don't want to be here that long. We don't want to be dealing with something that may or may not be needed for that patient. So again, getting cultures before antibiotics is key. Getting diagnostics before starting antibiotics is key. And always having a working diagnosis. Just because a patient has a fever or leukocytosis does not necessarily mean that they need antibiotics. We need to have a working diagnosis. Why are we maintaining that patient on antibiotics? Please ask each other that. And of course, when the frequent response I get, oh, they're getting better just because you had them on antibiotics for a few days, no longer works. We need to get answers for why the patient is on the antibiotic. And again, pushing pushing each other for reassessing the need for antibiotics at that 48 to 72 mark is really key. Here's another big thing I want to just bring up, colonization versus infection. Anytime there's an open wound, and I'm just going to give you an example for a wound, you're bound to see polymicrobial growth. So you'll see Staph aureus sometimes, you'll see coag-negative staph, diphtheroids, you'll see some Pseudomonas. This is very common to see polymicrobial growth in open wounds. What I'll see is a positive culture for a patient with an open wound, and I'll go and look at the wound and we'll evaluate the patient. Surrounding that wound, there won't be any warmth, there wouldn't be redness, there wouldn't be induration. The patient may not have tenderness. They may have tenderness if they have venous stasis, but really the culture should be obtained when the clinical signs suggest infection. So if there aren't clinical signs to suggest infection, we shouldn't even be getting those cultures in the first place. But what we end up doing is we end up mopping up those antibiotics needs after cultures have been obtained. So here's where we really need to get cultures after clinical assessment. Before, when I said when the patient came into the ED, we need to get cultures before starting antibiotics. Here we need to step back and assess clinically before the patient gets started patient can get started. We can always stop antibiotics if they clinically don't, if it's clinically not consistent with the organisms that grow in that wound. Same thing with bronchitis. Many cases of bronchitis in that first week, people can come to me dying saying, I feel horrible, I feel bad, I'm coughing up green stuff, I feel feverish, I have a fever. You can have all of those things, but in that first few days, if you're not dropping pressures, you should not be getting antibiotics. Let the viral infection do its thing, and after a week or so, if you still, the other day, one of my colleagues said to me, oh, I'm feeling really, I feel really bad, run down. And she said that she had the viral illness for about a week and a half or so. She felt better. So about a week she felt ill, she felt better, and then about 3-4 days later she felt worse again. So that is when you need antibiotics, after you have a phase of feeling bad, then you feel better for a few days, and then you have a second phase where you're starting to feel bad again with fevers and coughing up sputum that's just multicolored. That's when you need antibiotics. So it's really in that first few days, patients don't need antibiotics, and that goes along with not just chronic bronchitis, but that goes with pneumonia. Patients can have viral pneumonias. Patients can have asymptomatic bacteria. Here's another big one. I see this all the time in the outpatient and inpatient setting, where I get referrals for patients with organisms in their urine without the patient being symptomatic. So because they're going for this surgery or that surgery, they come with a positive urine culture. When you ask them details about, the patient comes to me saying, oh, I have a UTI. I said, well, what are your symptoms? I have a UTI, I was referred here for a UTI. It's not the UTI that are symptomatic. It's really, are you having burning? Are you having suprapubic pain? Are you having chills? Are you having back pain? The questions that we ask about their symptoms will help us lead to whether they really need the antibiotics or not. So many times I send them right back to where they came from without antibiotics, and they do much better after that. There are a few times where if they have symptoms, I've had them come back and repeat the urine analysis as well as the cultures to decide on whether they need treatment. But it's really a combination of symptoms, studies, and the organism to decide on what antibiotics they need, if at all. And this is just to show that white count and fever is a good response. So when there's an exaggerated or an abnormal fever, prolonged fever, or persistent leukocytosis of unclear etiologies, then we can jump at being infection as an etiology. But otherwise, having a white count is okay. The patient is here for multiple reasons, and they can have leukocytosis and fever, but they don't necessarily have to have an infection to go along with it. They could, but that needs to be assessed clinically. I just wanted to bring up the three scenarios that I just briefly touched on. UTIs, pneumonias, and cellulitis, because this is what patients come in. It almost seems that every person who gets admitted has a UTI, or they've got a pneumonia, or they've got cellulitis. And I just want to clarify a few things so that you can all discuss that amongst all of us, really. So UTIs are not diagnosed by urine cultures. I just want to put that out there, that when urine cultures are obtained and we get a positive culture of an E. coli or Enterobacter or Klebsiella, that does not equate to having a urinary tract infection. Just like I said earlier, it's the combination of having symptoms, physical exam findings, and an abnormal UA with the culture that helps to decide what antibiotic to choose. But it's really that history that helps us, and the exam that helps us to decide whether we need to treat or not. And many times it may not just be a UTI, it could be a vaginitis. I had a patient swear that she had a UTI, but when you just evaluate her, she has a florid candidiasis, groin perineal candidiasis. Once you treated that, the symptoms are resolved, and all of a sudden it's no longer a UTI in her mind. And sometimes in the outpatient setting, patients do come and say that they have symptoms, and I trust that. And when a person knows they've had UTIs in the past and they come to me and say that they have those dysuria and abdominal complaints, the likelihood of them having a true infection is great, so I treat them empirically based on historical urine cultures. If it's a young person who otherwise can give me a reliable, appropriate history, they don't need all of those studies I just talked about. There are other situations where you can have pyuria. So this is another thing where we can go into this later if we wanted to. But white count in the urine does not necessarily mean UTIs as well. So the cutoff at the system level for catheter-associated urinary tract infection is is 5. We're actually moving it to 10. But there are other situations where you can find pyuria. Stones are big. So nephrolithiasis, urodural lithiasis, you'll find we find that consistently that they have pyuria. Acute kidney injury, you'll have pyuria. STDs, bowel issues, you can have pyuria. Patients who have had catheters, prolonged Foley catheters, would have pyuria. They'll have polymicrobial organisms. They don't necessarily have to be treated. So I just want to bring up that pyuria in the setting where it's chronic or with an alternate etiology, they don't need antibiotics. Asymptomatic bacteria, they're just criteria here when you see that. If they don't have symptoms, they have a positive culture, urine culture, they don't need to be treated unless they're pregnant or they've had a recent urologic procedure. So if they've seen urology, they've had something done, they don't need antibiotics. You can just see this chart I put up here, various patient populations, diabetics, elderly, skilled facilities, patients with chronic indwelling Foley catheters. This is pretty telling. 100% of them will have positive growth. So when we culture that catheterized patient in that ED, we should expect growth from that urine specimen and not jump on treating that just because it's a positive culture. Majority of the patients that come into our hospital are in the bottom category here. They're elderly, long-term care. Many of them have had spinal cord injury and they have chronic indwelling catheters. So this should just take us back to say, if majority of our patients that are out there are asymptomatic and they have bacteria in the urine, they may not necessarily need to be treated. Again, this has to be assessed clinically, but data shows that we should be finding organisms in the urine in those situations. So, and it's also shown that patients who are delirious and elderly, that multiple studies have shown that by giving them antibiotics, we're not going to be changing that delirious state. So we will find many elderly patients who will become delirious for various reasons, not necessarily UTIs. So again, when do we treat them? When they have recently undergone a urologic procedure or they're pregnant. Next, I just want to bring up is pneumonia, which we see all the time because of an abnormal chest x-ray, right? No. So an abnormal chest x-ray should not gear us towards treating for pneumonia. It's that cough, it's that shortness of breath, it's the pleuritic chest pain, the fever. It's a syndrome of findings and history that should suggest whether we should treat for pneumonia or not. We can find abnormal chest x-rays. This isn't the greatest chest x-ray, but you can find it's abnormal though. But to multiple reasons, whether it's because they're bleeding, whether they're in CHF, just atelectasis post-op. I have a patient who's in-house who's here with pelvic injury from multiple hospitalizations, and she thinks she's here for pneumonia. And I said, no, you don't have pneumonia. You have Staph aureus bacteremia from hardware that's in the pelvis. So they're pretty convinced that once they hear that they have an abnormal chest x-ray, that they need to be treated for pneumonia. And that's what they're in for on a recurrent basis. So it's a difficult myth to break on some of these patients, but it's really all I hope we can all work on that together to break it. Again, we really don't need to treat abnormal x-rays. We can find pneumonia in just 30% of the patients that are treated. We don't even find pneumonia. So it's interesting, and there have been studies to show that majority of pneumonias, we don't even have we can't even get a positive culture on. So the sputum cultures that we send on patients who we suspect have pneumonias, and we don't find a positive culture, and we clinically suspect they have pneumonia, let's treat them as pneumonia. But if we find a positive culture from a trach aspirate or a sputum culture, and clinically and radiographically it's not consistent with pneumonia, they don't need to be treated just because they have a positive culture. I hope that made sense. So these are situations where we can wait and watch acute bronchitis, colds, so flu-like illnesses. So there are various viruses that are out there that we can find now with the respiratory pathogen panel you all might have noticed. It's a PCR, it's a DNA, RNA, PCR based study. And it doesn't just pick up flu, it picks up metapneumovirus, rhinovirus, enterovirus, a whole bunch of viruses that patients can be ill for 2, 3, 4 weeks sometimes. Sometimes I see post-viral inflammatory processes where they then need steroids. So they really don't even need antibiotics. So that's something that we end up treating. Pharyngitis, of course, not related to strep, we don't need antibiotics for. The last topic in terms of management is cellulitis. So this is actual cellulitis. So here there's bullae. We see that it's unilateral. One leg is more swollen than the other. It's would have been hot if we could touch it, and it's it's erythematous up to mid calf. So this is a true cellulitis. Can anyone tell me what this might look like? Venostasis. Yes. So this could be due to CHF. It could be due to liver failure, just chronic lymphedema. So we see this all the time, and we end up getting called for bilateral cellulitis, which doesn't exist. So when you see bilateral cellulitis out there, please question somebody, because it should be unilateral if it's cellulitis. Bilateral cellulitis is really venostasis. You could have unilateral cellulitis in a patient with venostasis, bilateral venostasis, but it's really the unilateral cellulitis that we're treating. So it's that one leg that might be more hot, more swollen, or more tender than the other leg. Venostasis can get pretty hot and warm and tender. That's just chronic fluid that just has no place to go unless they develop bullae and they leak out and find a way to leak out. But otherwise, this is exactly what we would see. What does this look like? This is similar to the previous one. Does look like venostasis. Stasis dermatitis is what this is supposed to look like. But this is where it gets itchy and scaly, and it's bilateral, edematous, warm, and can be erythematous. So it's, again, if it's bilateral, it's not cellulitis. Okay? And the last one, here is a unilateral erythema and edema. DVT, yes, yes, exactly right. So DVT is just diffuse erythema, warmth, and calf tenderness. But there is a distinction between DVTs and cellulitis. Over time, you would have seen that cellulitis, there's a demarcation where they are no longer tender. They are very tender where you have cellulitis, whereas DVTs, they're tender, particularly in the calf, where that cord, where they've got the thrombus in that vein, they're more symptomatic. So now because we've all said so much about don't use antibiotics for so long, antibiotics have a lot of side effects. Finally, they've been able to show some studies where we can stop antibiotics at a particular duration. So if it's a community-acquired pneumonia, we can get away with 3 to 5 days of antibiotics. So if patients come in and patients are placed on antibiotics for 10 or 14 days, please ask why the patient needs to be on the antibiotics for that long. If patients they come in with pyelonephritis, we can stop antibiotics in 5 to 7 days. If they have intra-abdominal infection, even post-op, we can stop antibiotics in about 4 days. I have to give these guys about 7 days, so we can all agree and meet halfway. And of course, cellulitis, like I said, after 5 to 7 days, if we don't see a response, many patients with cellulitis, all they need is compression and elevation. So after 5 or 7 days, the infectious process is gone. What we're left with is the vasculitic process and congestion and the symptoms related to that. So for that, you may see sometimes patients come back with recurrent cellulitis. It's not the recurrent cellulitis part, it's the recurrent edema part that they come in for. And we see this often, right? We're challenging patients more and more in the hospital where they are told that they have a penicillin allergy. Oh, they have had penicillin, that they were allergic when they were a child. Many times, if you ask these patients, they don't even know what allergies they've had. They tell you, oh, I was a child, my mom told me I had penicillin allergy, my mom's mom had it, I have it. So there are a lot of myths out there. About 10% of the patients will come to us telling us that they have a penicillin allergy. Ultimately, what's been found is just 1% of that 10% have a true IgE-mediated allergy. A full-blown rash would occur within an hour, and they are ill fast. So that's a true IgE-mediated allergy related to penicillin. Most of the other patients that we're seeing really don't have a penicillin allergy, and what you'll see us doing is just challenging those patients. Once we get a pretty good history that they just had a rash with penicillin, it's been shown that we can challenge them with cephalosporins. So you'll probably see us doing where we can challenge them more. And ultimately, why do we need to do this? Because of that patient who doesn't have a multi-drug resistant organism and they have an ampicillin susceptible enterococcus in their blood. I don't want to be giving vancomycin. I want to be able to give them ampicillin. And if they tell me that they've got some allergy that really wasn't an allergy, I am not doing them right by giving them vancomycin. So I think this is really important for all of us to know when we can challenge a patient and when it's okay to challenge patients with penicillin allergies. And this is something I just want to bring up. It's an antibiogram. I've been asked from time to time to just briefly discuss what it is. It looks more complicated than it actually is. And what I wanted to just briefly bring up is this is for 2017. What they show is most of the gram-negative organisms, and you'll see the majority of our isolates here is about 2,000 isolates of E. coli. And on the x-axis, I guess, if you will, there you'll see the antibiotic classes. So you'll see ampicillin, cefazolin, cefoxitin, ceftriaxone, ciprofloxacin, ertapenem, gentamicin, levofloxacin, piptazo, Bactrim. So they list out antibiotics on going this way, and they list out organisms this way. What they show here are the susceptible isolates. So you can see here, E. coli, only 54% of the 2,000 isolates are ampicillin susceptible. So we should not be using ampicillin in those cases. So that's where this antibiogram is really helpful, is we can go and check our 2017 isolates of all the organisms at our hospital, and we can look at the organism, we can match it to the antibiotic that patient's on, and we can tell whether levofloxacin for Klebsiella oxytoca was appropriate or not. For Proteus mirabilis, not so great. It's about 72% susceptible. Cipro for Proteus mirabilis is only about 67% susceptible. So many times I'm just going back to saying, oh, what is really appropriate for this community based on our isolates that we've identified and checked against various antibiotics. So that's what the antibiogram is. All of us can use it. We can all say whether that for that particular bug, was this the appropriate drug? And the same thing with the gram-positives, the Enterococcus, the Staph aureus, and here are yeast species. So our antibiogram should be heavily used by all of us, and it's on the front page of the Sutter website. So ultimately, I just want to bring up, again, kind of summarize the antimicrobial stewardship program. All of us are part of this. We should all be reevaluating our working diagnosis in the first 48, 72 hours. We should not be using multiple antibiotic classes if we don't need them. Sometimes you may see nafcillin and cefazolin used. Those are two beta-lactam antibiotics, and that increases the risk of seizures or the beta-lactam side effects. You'll see Zosyn and Flagyl used by some of our clinicians. That's two double anaerobic coverage that we don't need. Again, the more pressure we put on these bugs by these antibiotics, the more we select out the drug-resistant bugs. So that's the idea of trying to do this. And really, there are many scenarios where we can sit back and watch and see what happens before we jump on antibiotics. Endocarditis is one of them, osteomyelitis. Those chronic foot ulcers that patients come in with from the ED wanting to jump on antibiotics right away, we don't need to. We can wait until we get some cultures, and when the podiatrist takes them for bone biopsies or resection, we can then decide what antibiotics they need. Of course, if they don't have the sepsis criteria. This is all without sepsis. And ultimately, we want to decrease antimicrobial use. Why? Because we don't have very many down the pipeline for new classes to cover our gram-negatives. We're really using with the ones that we already have. We need to appropriately, responsibly use them. We want to bring our C. diff rates down in the community because we don't want to be seeing them and having to see mortality associated with those 14,000 deaths that we saw with C. diff. All in all, the more we use antibiotics responsibly, it goes back to making that appropriate diagnosis to begin with, so we can bring down the cost for patients, families, and healthcare in general. And really, there are so many handouts out there by CDC to bring the use of antibiotics down. And ultimately, I just put this slide out here. John Bartlett's a big infectious disease doc in the East Coast. And really, we need to make each other more aware of when antibiotics are useful, when they're not useful, and really stop and get people to think. Out in the community, I try, whenever I go out there and I'm out there with my kids at soccer games, when other parents come to me and talk to me about antibiotics, that's the first thing I say is maybe we don't need antibiotics. We just need to wait and see whether someone needs antibiotics or not. And it brings a different realization to many people that they haven't had, it seems like. But really, all of us, community providers, all of you, dentists, patients, I need to include patients in all of this because this is something that we're going to be dealing with over the next 15, 20, 30 years. I really don't want to be seeing carbapenem-resistant Enterobacter CA in this hospital, and I think we're doing great with the types of resistance we are seeing, and we're able to control those infections, but I think there's always room for improvement. So this says, don't forget to take a handful of our complementary antibiotics on your way out. And that is what a lot of people are seeing in their doctor offices, in the ED, and all of us are in a place where we can really help each other, teach everybody out there to minimize the use of antimicrobials when we don't need them. Thank you. Any questions? Yes?
So when we admit a patient, we have to go through, do you have any allergies? Well, what are your, responses to that? And if they say, oh, it just made me nauseous.
Oh.
Well, I'm like, that's not an allergy,
Absolutely.
That's a symptom.
Right.
Can we take that off their list?
Yes.
Should we leave it on their list? Should we?
Absolutely, you can take it off. Nauseousness is not an allergy. Sometimes I find nephrologists put a certain antibiotic on their allergy list because they end up with acute kidney injury, and it alerts somebody that an antibiotic can do that, and so they put them in the allergy list. I'm okay with that because all of us should be responsible about when not to use an antibiotic to not cause acute kidney injury. But if they say they're just nauseous, please remove that from their
Same thing with
allergy
Norco.
list.
No, I can't take Norco, it makes me nauseous.
So that's not an allergy.
Exactly. So, but we can change that. Nobody's allergic to gelato.
I'm not sure about that. Like, who makes that change? I think Jackie Koo is out there. She's, wave your hand. She's the ID pharmacist who works with me. We were talking about that earlier today because I was just talking to her to say, we should be taking medications off the allergy list when there are not allergies. And she was saying, who should be doing that part? I think we need to work on that as a hospital more to see who should be removing medications off the